Thus, while it is clear that we are dealing with a highly complex problem with many causal pathways and no single causative factor, gender services tend towards a very damaging, peculiar, superficial simplification. For various reasons, not least a huge increase in caseloads, the long waiting lists, leading to pressures to process the children using a procedural model rather than one aimed at understanding the individual case in any depth. The great problem of the Tavistock service is it's a gateway. Rather than being separate, it's a gateway to puberty blockers. Of course, alignment with affirmative lobbies, that is, lobbies that seek to affirm the wish to change gender, tending to see it only as a positive choice to be encouraged, acts as an ideological support for this simplification. Many services lack any understanding of and are overtly hostile to any thought about the less manifest, less conscious issues in which ways that they are not for other disorders. So trans is somehow exceptionalized. Even thinking about cause is very often regarded as an act of hostility. For the only acceptable explanation is that the child is literally in the wrong body. And all suffering is secondary to this, in inverted commas, fact. It needs to be borne in mind there's absolutely no evidence at all for this assertion. It's a kind of belief, it's a kind of essentialist belief in some kind of gendered soul. Even mermaids have stopped using that term. We also need to distinguish a child's subjective account from a more external perspective. Patient involvement in decision-making is, of course, a good thing, but that needs to be distinguished from the non-questioning of the patient's account. When it becomes non-questioning, here we see a perversion of clinical care into a kind of customership, where the customer is always right. And this is perversely championed as patient engagement. Some guidelines accept that if a child is disturbed by being trans, then they do need psychological help, with the implication, most peculiar, that if they are not disturbed, there's no need for help. In fact, one could argue the exact opposite. Non-disturbance is more likely a sign of dissociation from the implications of pursuing transition. There's also a tendency, which I think Jude has helped us with, and also Stella's paper, to sanitize interventions, which are presented, discussed in such a way as to downplay their nature and the lifelong implications, being a patient for the rest of your life, anorgasmia, infertility. Sometimes it's even made to sound like minor cosmetic surgery, sometimes referred to as top surgery, as opposed to double mastectomy. I recently just heard of a Scottish 16-year-old child who's had a double mastectomy. I and many colleagues have seen adult patients where genital surgery has resulted in, apart from the inevitable complications, further complications because of the surgery going wrong. A number of surgeons are now expressing very serious doubt and concern, as if they're suddenly waking up to what's happened.